Hello, I'm Professor Patrick McGorry. Welcome to today's webinar. Before we proceed, as Executive Director of Orygen, I would like to acknowledge the traditional custodians of the land on which we work around Australia and pay my respects to elders both past and present.
Welcome to the Orygen webinar, Autism and Comorbid Mental Health Conditions in Adolescents and Young People. My name is Johanna Rouse and I am the current Neurodevelopmental Disorders Coordinator in our neurodevelopmental stream at Orygen Youth Health Clinical Program in Melbourne, and I'm also a Senior Occupational Therapist.
And I'm Melanie Cook. I'm a Senior Clinical Psychologist with Orygen Youth Health and also work in the neurodevelopmental stream.
So today we're going to spend some time looking at what are autism spectrum disorders, give you a brief history of autism spectrum disorders, talk to you a little bit about what we know about the current etiology of ASDs, spend time talking about how autism spectrum disorders are currently diagnosed, so specifically what are the traits of ASD required to make a diagnosis, and think a lot about how these traits present in adolescents and young people. We're going to give you an overview of the diagnostic process and talk to you about the diagnostic challenges, including comorbidities and differential diagnosis that we commonly see here at Orygen. And we will finish off with letting you know about how you can learn more in this area.
And just a note on terminology as well, you'll hear us throughout this webinar using a variety of terms like autism, ASD, autism spectrum disorder, the spectrum, or Asperger's, for instance, and that kind of reflects the diversity of terms that people with autism like to use. So we like to reflect that in our use of language as well.
So firstly, I guess we want to answer the question, what are autism spectrum disorders? So according to the DSM, autism spectrum disorders are classified currently under neurodevelopmental disorders. And so this means that ASD and other neurodevelopmental disorders typically manifest during the developmental period, and to make a diagnosis they need to cause significant impairments across functional domains, so in personal, social, academic and occupational functioning. Currently, autism spectrum disorders are thought to be a range of conditions that have common features across persistent deficits in social communication and interaction, but also the presence of restrictive repetitive behaviours, patterns of behaviours and interests or activities. So in short, ASDs are lifelong neurodevelopmental differences, and currently the literature is indicating that in America, ASDs affect up to 1 in 68 people, and estimates in Australia have been around 1% of the population, so a similar prevalence to something like schizophrenia. We will spend some time talking about how you diagnose ASDs later in the webinar, but for now we will just start to talk a little bit more about the different types of ASD and the diversity related to autism. So there's a lovely quote that we often use in our trainings in relation to ASD. So if you've met one person with autism, you've met one person with autism. And this gives us a snapshot about the fact that we can't assume that everybody's experiences of ASDs are the same, and that everybody will have different strengths and different areas of difficulty. Jeanette Purkis, who's a consumer advocate in the area of autism spectrum disorders and an autistic person herself, says that there are different types of autism rather than one type that differs only in terms of severity. So if we think about the diversity of autism spectrum disorders, this is a nice little diagram that kind of helps you think about the fact that we are going to see a range of different presentations. So if we think about the different domains of ASD diagnosis, we know that people with autism will have some difficulty in communication. That's part of the diagnostic criteria. But people can range from being extremely verbal and having excellent verbal skills, all the way down to people who might be non-verbal in their communication and have no language at all. Also, in terms of social interactions, we know that there are lots of people with autism spectrum disorders who have some great social skills, but others who have lots of social difficulties. And so people with ASD can present as quite aloof or keep to themselves, all the way through to passive in social interactions, and at the other end of the spectrum can present as quite hypersocial and active and a bit odd in different social settings. Again, in terms of other diagnostic criteria, we know people can present with a range of restricted and repetitive behaviours and interests. And again, these might present in a mild, subtle way in a person's life, or they might present as more marked and obvious to other people. People also present with sensory processing difficulties, so they can be hypersensitive to certain stimuli. That means they are more likely to notice and pay attention and be bothered by certain stimuli, like bright lights, for example, or loud noises, all the way through to being under-responsive to sensory stimuli, so maybe missing out on certain sensations such as pain or temperature. We also know that people with autism spectrum disorders can present with a range of cognitive abilities. So some people with autism spectrum disorders have severe intellectual disabilities. Others can present as quite gifted and quite brilliant in certain areas. And along with that, we also know that like anyone else in the population, people with autism spectrum disorders have a range of different learning styles and strengths and abilities, and then areas of learning difficulty that we need to take into account in our work with them. So just touching a little bit more on where this term autism comes from. So we first heard the term autism back in 1943 when Leo Kanner, psychiatrist, wrote a paper called Autistic Disturbances of Affective Contact, where he described cases of 11 young children, all boys, who appeared socially withdrawn and they were engaging in repetitive type behaviours. At this stage, autistic traits were seen to be a part of childhood schizophrenia, so it wasn't differentiated at that stage. 25 years later, in 1968, the second edition of the DSM came out, and autism was included again as a feature of schizophrenia. And then in editions 3, 4 and 5, what we have currently, autism has been classified as its own disorder. And you will see if you look back through the different versions of the DSM, that the diagnostic terminology and features have been further developed and refined based on the research evidence, like other mental health conditions. So a big area of conversation in the mental health world, but also out in the community is, what do we know about what causes autism? And largely we say that the exact cause of autism spectrum disorders remains unknown. Researchers continue to investigate a range of possible causes, including genetic factors. So there have been multiple genes identified that appear to be involved in the development of autism, as well as de novo, so spontaneous mutations that may also occur. Coupled with that, we also know that there perhaps are environmental influences that might be impacting on autism developing in people, and these factors might include viral infections, pregnancy complications, air pollutants, and vitamin D deficiencies, just to name a few. It's most likely, we think, and the literature indicates that the cause of autism is probably an interaction between genetic and environmental factors. If you are interested in reading more about these factors, feel free to have a look at our reference list, and there'll be some more articles and things that you can refer to there.
So we're going to move on now to having a think about how autism spectrum disorders present in adolescents and young people. And we've alluded to the DSM, so we'll take a look at the DSM-5 ASD criteria. The DSM-5 looks at two areas of functioning. It looks at social communication and interaction, and at restricted and repetitive behaviours. And these two areas of difficulties need to have been present in the developmental period, so throughout childhood, and also be current difficulties. Now, the nature of these difficulties can change, obviously, throughout childhood to adolescence and adulthood. And sometimes we find, especially with young people that come along to Orygen, is that they might have had more subtle kind of difficulties in childhood that meant that they didn't receive a diagnosis at that time. But then as the sort of demands of adolescence and young adulthood become greater, and a person is required to sort of develop more living independent skills, and has sort of less structure and support from family and school, then some of these difficulties might become a bit more apparent, and so then they might receive a diagnosis later in life. So thinking about these areas in a bit more detail, Joe's already mentioned some of the social communication difficulties that we would look at. The first of these is social emotional reciprocity. So we use the term reciprocity because we're interested in the back and forth relationship between a person with autism and another person. So we're interested in how a person approaches a social situation. Do they sort of have an approach that's a bit unusual? How do they go in back and forth conversation? So again, that reciprocal kind of nature of socialising. How do they go with reciprocal sort of recognition of emotional experience as well? So understanding their own emotional experience, but then recognising and understanding other people's emotional experience and kind of adapting their social approach in sort of an appropriate way. Yeah. So we might see some of those difficulties. We might also see just kind of failure to initiate social approach as well. That could be how that would look. We might see some differences in non-verbal communication as well. I think the one feature that most people would kind of more easily notice is some differences in eye contact. So it could be a lack of eye contact or reduced use of eye contact, or it could be that eye contact is just a little bit unusual. So it might be kind of unusually integrated with the rest of their social behaviours, or it might be sort of a bit fixed or something that's kind of been learned along the way, and so it doesn't sort of have a natural kind of flow that you might see in someone without autism. Other features that we might notice in terms of non-verbal communication are facial expression. There might be less facial expression, there might be no facial expression whatsoever, or there might actually be exaggerated facial expression, again, that sort of seems a little bit unusually kind of integrated with the rest of their communication behaviours. We might see some differences with gesture as well, so it might be reduced use of gesture or kind of a learned and exaggerated use of gesture. And use of body language as well, so just the way that you hold your body in conversation communicates a lot as well, and sometimes that can be a little bit unusual or lacking as well. The last area that we're interested in is around the quality of relationships. And it's not surprising to notice that if a person has social emotional reciprocity difficulties, has some difficulties with non-verbal communication, that they're probably going to have some difficulties in their relationships as well. And so we would expect someone with autism to have some types of difficulties with sort of developing, maintaining and initiating relationships with other people. So especially same age peer relationships tend to be a bit more difficult for people with autism to create. They might be more likely to have closer connections with older people in their lives, or maybe with younger siblings, for instance. But we would notice some type of difficulty in social relationships throughout the lifespan. So from sort of, from prep or preschool right through to primary school, we might there might be examples of bullying, for instance, and social exclusion in a person's developmental history. And there might be only sort of one or two close friendships or no friends at all sometimes in the adolescents and young people that we work with.
And from a social perspective, we often find that adolescence and young adulthood, I guess, is a peak time for people to present to mental health services if they have an undiagnosed autism spectrum disorder, particularly if they've had subtle social difficulties and communication difficulties. And that can be because the social demands that are required of us as people increase as life goes on. So you hit adolescence and it's a tricky social stage, as is kind of moving into adulthood. So that's when I guess the world can be more confusing for people with autism spectrum disorders, and they can perhaps start to feel more and more socially isolated or worried about their social approach, which can then contribute to other mental health conditions like depression and anxiety, which we'll talk about a little bit later.
Yeah. And so you'll see on the slide there that to receive the diagnosis, a person would need to have all three of those areas present in terms of social communication. Taking a look at restricted and repetitive behaviours, there's four criteria that we're interested in there, and a person would need two of them in order to receive a diagnosis, again, sort of present in the developmental and period and currently. So thinking about repetitive behaviours, that again will look quite different, I think, for younger children than it will for adolescents and young people. For children, you might see behaviours more like lining up toys or kind of simple motor movements that are repeated, like rocking or tapping or knocking on things. For adolescents and young people, we'd be more likely to see perhaps repetitive speech patterns that they might use. They might, for instance, repeat, they might know the scripts of their favourite movie show and kind of repeat that over and over again. They might have certain catchphrases that they use. They might have certain kind of nervous behaviours that they might repeat over and over again, like it could be tapping on a leg or rubbing on a leg. Do you have any other examples, Jo?
Or pacing.
Pacing,
yeah, which again can be tricky to differentiate whether that is truly related to an autism spectrum disorder or perhaps an experience of anxiety. So again, we'll talk about that later in the presentation.
Yeah, and so another feature that we often see and that a lot of therapists will kind of come to us to talk about is inflexibility in behaviour and thinking. So rigid thinking is a really classic feature of autism. We know that people with autism tend to sort of have quite rigid black and white or all or nothing thinking. And that can make it quite difficult to sort of be flexible in terms of responding to, you know, different environmental demands, day to day, change of routine, unexpected change of plans, things like that can be really tough. It also means that they're more likely to experience pretty extreme distress actually with change of plans and with, especially if they're unexpected changes. Yeah. So it might also look like needing to sort of have the same routine every day, so having like a really kind of rigid routine in the way they like to do things, taking the same kind of route to work or to school, needing to eat the same foods, things like that. That kind of repetitive behaviour and doing the same things over and over again is actually really kind of soothing for a person with autism. They really like to do the same things over and over again.
Yeah, and it can be quite upsetting if they're taken out of their usual context. For example, for admission to an inpatient unit, it can be very challenging and overwhelming for people if they can't engage in their usual ritualistic behaviours that help them feel safe and soothed. So just keep that in mind if you're working with people in an acute setting.
Yeah. And so, you know, with a preference for repetitive behaviours and rigid thinking, it's perhaps not surprising that people with autism tend to have quite restricted interests as well. You know, and we can all have really strong interests in different things, but people with autism have very fixed and strong restricted interests that can be really quite all-encompassing, and that a person, if left to their own devices, would really spend all of their time thinking about and doing this thing. So if it was cats, you know, they would be spending all of their time playing with cats, researching cats, looking at pictures of cats, watching cat videos, etc., etc. And if you happen to touch on that topic in conversation with them, they'll be really, really interested to talk a lot about that. Whether or not you have a particular interest in that or not. Yeah.
The other thing to make mention about with regards to restricted interests is that, you know, it's often very fantastic that people can develop these interest areas and develop lots of skills and abilities in these areas, or lots of knowledge about a certain topic. And I guess we often only see it becomes an issue so much when a person is engaging in only that restricted interest, and it might be impacting on their functioning in other parts of life, such as getting to school or going to work and those kinds of things, or they're isolating themselves completely from a social perspective.
Yeah, that's right. And so the last criterion that we're interested in is hyper or hyporeactivity to sensory input. So Jo already mentioned a little bit about this. So hypersensitivity being, you know, extra sensitive to sensory input. So we might see that someone with autism might be particularly sensitive to touch, to noise, to lights, to different textures, for instance. Or they might have some hyposensitivity, so they might actually be undersensitive to certain sensory input, and that might include things like touch, it might include things like temperature or pain as well. And so we all have sensory preferences, that's a really normal thing, but these sensitivities are a bit more marked and tend to sort of get in the way and cause distress for people with autism. So these are the criteria that we're interested in looking at. As I said, we're interested in the developmental period and currently, and we're also interested in specifying the severity level. So level 1, meaning that they require some support, through to level 2 requiring more substantial support, and up to level 3 requiring very substantial support. And we'd be interested in differentiating whether there's an intellectual disability or something like ADHD or a language disorder comorbid with that. Yeah.
I also want to make mention that this image that we have up on the screen now, and also the next image we'll be showing you, we've popped some A4 PDF copies of those in your resource packs. So they might be a little bit hard to read on your these slide printouts if you print them, but just keep in mind there's the larger copies for you to refer to if you want to at a later date.
Yeah, thanks, Joe. So the next slide is one of the worksheets from our manual, and as Joe said, you will have a copy of this. This is a really nice way to talk about autism with young people, either that you're considering exploring the diagnosis with, or that they might already come to you with a diagnosis and you're interested in getting to know what their particular sort of autism profile looks like, what their strengths and difficulties are. It's a really nice tool to use because it's everyday language, it uses everyday examples. As I said, it focuses on strengths as well as things that might be challenging. And it covers a range of areas, so social difficulties, communication, behaviour, body, and thinking. And so I won't go through every single one of these, but I'll just point out a couple of them that are quite nice in terms of using everyday language to think about strengths and challenges. So some of the strengths, for instance, in thinking skills are, being good with facts and figures and details. We know that young people with autism tend to be quite good at noticing detail, and that means that they can be really fantastic researchers and have really amazing memory, for instance, photographic memory sometimes. So that's a really lovely strength. And an example of a difficulty on this sheet under communication is difficulty reading emotions in other people. And so that's just really nice kind of everyday language to describe some of those difficulties in social emotional reciprocity. Yeah. Did you want to say anything else about this slide, Joe?
No, I think it's just something that we tend to use a lot in our work with the people that we see, with the young people, also with family members, as a psychoeducational tool to provide them with some information about what we know about the young person. I also like to use it as a bit of a discussion tool with young people and their families when I first meet them, if they have already had a diagnosis of autism spectrum disorder, just for me to say, I really want to get to know you and how this applies for you as an individual. So we can just sit down and do a kind of a tick the box exercise, trying to work out what applies to them. Or there's a blank version as well that we use in the manual as well that has spots where you can write down, so people can actually use their own words to describe their strengths and difficulties. So it's a nice little tool that's worth keeping in mind. Yeah.
Great. So next up, we want to take a look at some of the underlying cognitive differences that young people with autism might experience. I feel like it's really useful to have a think about this at the start of kind of thinking about autism, and that's because for me, it really kind of provided a framework to make sense of some of the differences that we see in autism. Because, we just went through the diagnostic criteria. Some of them can seem a bit random, really. But when we think about the underlying cognitive differences, it really makes sense, I think. So if we start off, for instance, with theory of mind or mentalizing, this is one of the kind of core experiences that young people with autism have. So this is about their capacity to be able to have insight into their own emotional experience, have insight into their own thoughts, and to be able to kind of then perspective take and have awareness of other people's thoughts and feelings, and also awareness of kind of group perspectives as well. So we know that most people with autism will have some degree of difficulty with theory of mind or mentalizing, and I think it's really helpful to think about what the impact of these differences can look like. So, for instance, if we think about reduced awareness of your own emotions, that can really easily kind of translate to problems with emotion regulation, because when we have awareness of our own emotions, it means that we have that capacity to kind of pick up on our emotions when they're at a lower intensity or more kind of subtle experiences of that emotion. So, for instance, if we're thinking about anxiety, you might be able to pick up on kind of lower levels of nervousness, and then be able to kind of use some strategies to calm yourself down, right? Like do some slow breathing or something like that. Whereas if you don't have that insight into that lower level intensity of nervousness, you might actually not pick up that you're feeling anxious until you're almost feeling panicked, and by that stage it's much harder to downregulate.
Which is why we can see people with ASD often presenting with 0 to 100 type emotion scales, that they can go from, seemingly doing okay to meltdown or overwhelm very, very quickly.
Yeah, and that if you're doing therapy with a young person with autism, they might really struggle to kind of identify times when they're starting to feel nervous or starting to feel slightly anxious. For them, it's either panic or I'm fine. There's nothing in between. So that kind of makes sense when we think about these difficulties with theory of mind. And the same goes with reduced awareness of one's own thoughts. So really, it's just less information for the person to act on effectively. So if you're not aware that you're starting to have some anxious kind of catastrophic kind of thoughts, you're not going to be aware that maybe you need to start to try to challenge some of those thoughts, or that you need to do your slow breathing to sort of downregulate. And of course, if you're having trouble taking the perspective of others, that can lead to a bunch of social and relational difficulties as well. It can be hard to connect with other people when it's hard to take their perspective. It's hard to sort of preempt what they might need and to sort of provide that reciprocal kind of empathy and understanding. And it might also look like being a bit less concerned actually with what other people think of you as well, which in some ways can be a strength that can help young people with autism to kind of think outside the box in some ways and to have some really original and innovative kind of ideas about stuff. But it might also mean that you struggle to fit in as well.
And to build strong connections, like we talked about with regards to quality of relationships.
Yeah, that's right. So there's some of the differences around theory of mind. We'll have a think about this idea of central coherence as well. So central coherence is our ability to integrate kind of disparate pieces of information into a sort of coherent whole. So if you have, quite strong central coherence, that gives you the ability to comprehend and remember kind of the gist of things, It gives you the capacity to be able to integrate kind of multiple different bits of information into one whole. So, a really kind of simple example of this is, thinking about going into different counselling rooms, right? I sort of have a sense of what the function of a counselling room is, and it doesn't really matter to me which different room I go into, because for me, they've all got some seats, they've all got a table, they kind of do what I need them to do. I have a gist understanding of a counselling room. But if you have weak central coherence, it might actually be quite overwhelming to go into a different counselling room every time, because you'd be much more likely to focus on the details rather than focusing on kind of the central meaning of that experience. So the way that looks is, that detail is extremely important when you have weak central coherence, and so as I said, change to environment can be really, really overwhelming. The upside of that though is really excellent attention to detail. So I've been really surprised sometimes, like when I've bought a new therapy book and it's sitting on my bookshelf, and one of my clients with autism comes in and immediately can notice that I've bought a new book, and that's just quite an astonishing attention to detail. I don't think anybody else would have noticed that. So attention to detail is a fantastic feature. But it can translate to having difficulty generalising. So what that means is that you can then have trouble applying known responses to new situations. So again, an example of this is that a young person might learn how to cope with panic attacks at home and have like a set of kind of coping strategies that they use in that situation. But then it's actually really hard to apply those strategies at school because it's a totally different context, and you'd really need to think through what are the different ways that they can apply those learnings in a new context. Another feature of having difficulties with central coherence is, that it's difficult to see the bigger picture. So if it's difficult to see the bigger picture, it can be difficult to plan a sort of complex task with multiple parts to it. You might be more kind of focused on one step and really kind of get into the nitty-gritty and the detail of that without sort of thinking, oh, actually, I only have an hour to complete this task and there's 5 questions, so I can only allot, this much time for each question. And that can get you into trouble when you're trying to get stuff done.
Yeah. So looking towards a long-term goal is difficult for people.
Yeah, exactly. Yeah. And of course, social situations, are really complex situations as well and require being able to see the bigger picture and being able to kind of hone in and out on, details of what people are saying, but then thinking about the bigger picture of what's happening in a social situation and what the needs of the group are. And so if we sort of combine, some of the theory of mind difficulties with these central coherence difficulties, we can see that it would be quite easy to misinterpret social situations as well.
And find them pretty overwhelming.
Yeah, absolutely. And so there was a really nice little piece of research that looked at this idea of central coherence and some of the difficulties with that. We can see in this slide that on the consistent side, we've got the big S with the little s's that it's made up of, and same with the H. And then we've got the inconsistent use of letters, so the small h on the big S and the little s on the big H. And unsurprisingly, people with autism responded much faster to the smaller letters, so the small h in the big S. They were more likely to notice the small h, whereas people without autism always noticed and always responded faster to the big letters. Yeah, so it's a really kind of nifty illustration of central coherence. Yeah. The last cognitive difference that I wanted to focus on were issues around executive functioning. So executive functions are extremely important. They're kind of the underlying functions that we rely on day to day to plan, to organise, to control our behaviour, to monitor our behaviour, to get things done really from day to day. So really, really important functions. And we know that people with autism tend to have some differences in these areas. And some of these differences are like difficulties with abstract thinking, for instance. So people with autism tend to do much better with concrete kind of examples and concrete thinking about things in the here and now. Whereas abstract thinking requires us to kind of, think abstractly about things that have happened in the past, things that aren't immediately present, kind of theoretical notions like the future, for instance. And if we think about how that impacts on a person's life day to day, they're really kind of missing out on some capacity to kind of reflect on things that have happened to them in the past, on their past experiences, and missing out on that important information about how to adapt to what did and didn't work previously. So that can be really tough, especially with social difficulties, for instance. It might be harder to kind of learn from a social experience that didn't go that well. It can also show up with anxiety and depression as well. So kind of struggling to kind of see the triggers for times when they might be feeling more anxious or feeling worse in their mood, and not really putting the pieces together about how to do things differently to respond differently next time. We've already mentioned the rigid thinking, and we know that can make it really easy to get stuck in unhelpful thinking and responding, which is, one of the hallmarks of anxiety and mood disorders, isn't it? Yeah.
Which makes it, we talk about this more in the learning module, which you might want to go on to do, but we spend a lot of time thinking about how rigidity in thinking can make work in therapy tricky.
Absolutely.
Hard to shift negative thinking. Or challenge them.
That's right. And I think, as I mentioned, rigid thinking is something that therapists and parents will often sort of come to us as being consultants with Orygen around autism. People will come to us, really struggling about knowing how to work with rigid thinking.
Feeling quite challenged by it.
And Another issue that we see around executive functioning difficulties is problems around planning. So again, there's an interaction effect with the central coherence. So when you're more detail focused, it is harder to see the bigger picture. It's harder to plan. Therefore, it's harder to plan to achieve a desired outcome or to avoid a pitfall. And that's how that might play out. We've talked a bit about lack of flexibility already, and just the fact that that makes change so stressful and hard to adapt to for people with autism, and also makes it hard to see things from different perspectives. Yeah. And I mentioned that another important part of executive functioning is the capacity to sort of monitor or control our behaviour, and so that can lead to difficulties with disinhibition, which can look like poor emotion control. Again, when we combine that with theory of mind difficulties, there's this sort of interaction effect, so that people will be emotionally dysregulated due to lack of theory of mind or lack of insight into their own emotional experience, but then they're also quite disinhibited, so might be much more likely to sort of just react in the moment rather than to be able to have that kind of executive capacity to moderate their behaviour and respond in a different way. Yeah. Okay, so we'll keep moving along and just touch very briefly on some of the gender differences in diagnosis. So we know that autism is diagnosed 4 times as frequently in males as it is in females. There's a couple of theories for why this might be the case. One is the fact that, as Joe already mentioned back in 1943, the initial diagnostic criteria around autism were based on observations of groups of boys. And so, and boys with quite severe autism as well. So there's a very kind of, a very biased sample that they were looking at, and obviously not representative of young girls and women that were experiencing autism as well. So there's a historical context to this, but there's also a social kind of context to this as well, and that's called the camouflage or chameleon effect. So this is this idea that due to the way that girls are socialised differently to boys, to be more kind of in touch with their emotions, to be more kind of motivated towards caring relationships with other people, that they're better able to kind of mask or compensate for their autistic difficulties than boys are, just because they've had a bit more training, basically. So that's the camouflage or chameleon effect. There is some evidence that girls tend to have less repetitive and restricted interests than boys as well. And that might be part of why it gets missed, because repetitive behaviours are quite obvious and can often be things that teachers might flag in school as being an issue, because it's disruptive and it's getting in the way.
And sometimes the restricted interests in females or in young girls can perhaps look a little bit more socially appropriate on the surface, and less obvious to what the boys might present with. So again, that can be subtle and fly under the radar of different support people in their lives.
Yeah, that's right. So just touching on this idea of gender differences, there is a big movement at the moment of female advocates in the autism area, trying to sort of get practitioners on board with being able to notice some of the more subtle presentations of autism in women.
Yeah, and lots of research developing in this area too. Okay, so moving on, we're just going to spend a little bit of time talking about how we go about diagnosing autism spectrum disorders in adolescents and young people. So specifically talking about the diagnostic process. We're only going to briefly cover this today in the webinar because diagnostic assessment for autism is quite a specialist area, and we certainly don't expect that you should feel like you're an expert in diagnosing ASD after kind of listening to this presentation. We just feel that it is helpful to give you a snapshot around how it's done and share with you some of the, the tools that we might use, and some of the considerations in thinking about if you're working with somebody, whether a diagnostic assessment is warranted. So firstly, just to mention some screening tools. Certainly screening tools are not perfect, and I guess they're not perfect for mental health settings either, because these autism screening tools are designed to pick up autism spectrum disorder traits in people without comorbid mental health conditions in general. And what we find often when we utilise them here at Orygen is that we can use them as a discussion tool with clinicians that we're working with, or to get some context from the young person and their families around what is happening, and helping kind of give us a bit of a flavour about whether we think a full diagnostic assessment is required. But they're certainly not the be-all and end-all in what we would utilise. So just to mention a few screens that you might want to have a look into if you're interested, and you're welcome to go away. We've put these in the reference list, and also I've popped some links to the screens that are freely downloadable online in your resource pack as well, so that you can go away and have a look at them yourselves. Often when we're consulting with clinicians here at Orygen around whether we are thinking about proceeding with a diagnostic assessment for a young person, is we use something called the Autism Spectrum Disorder in Adults Screening Questionnaire, so the ASDASC. So basically it's a 10-question questionnaire that we utilise in consultation with clinicians, and it gives some prompts for us to guide our discussion around looking for potential ASD traits in young people. It's an adult screening questionnaire, so it is, the literature certainly indicates that it is it's a good tool to use in the adult population. So we tend to use it with the young adult population, and it's a yes/no questionnaire, so it's quite an easy, user-friendly tool to use. If you're looking for some self-report tools, you can do something called the Autism Quotient. So you can do a shortened version of that, the AQ10, or you could do the full get the young person to fill out the AQ50. So either of those options are good, and they have a scoring key that's available with them. And basically there's a cut-off score. So if a person is scoring highly on the AQ10, for example, I think it's from memory at 6 and above, then that would warrant us moving forward with a further assessment. But it is self-report, so it is requiring the young people to have some insight into their difficulties. There's also the RITFO Autism Asperger Diagnostic Scale Revised, which is a very, very lengthy questionnaire that I haven't tended to utilise so much in my practice just because of the length of it. But it's certainly other colleagues have reported that it does give a wealth of information if you've got somebody who can engage in that process. And as with any understanding of a person's mental health difficulties, it's also important to ask other people in their lives to give some feedback. So the Autism Spectrum Screening Questionnaire, which is a screening questionnaire looking at people with high functioning ASD or low support needs, now the autistic community say. It's a 27-question questionnaire that's available online, and it asks parents or another informant to inform some information about ASD traits. So there's some tools you might want to have a look at, and you probably want to go away and have a look at the literature and see how they might be applied to your specific context. So thinking about what does an autism spectrum disorders assessment involve, we are, I guess, kind of putting up here the gold standard for what we would recommend and ideally do in autism spectrum disorders assessments. It's not always possible to do that, but we do try where we can, and we know, depending on what context you work in, you might have different professionals around you who can support you with this process. You might work in quite an isolated role, and you might have to think creatively about how you might gather this information or involve other mental health professionals to help inform the overall outcome. But the best practice that we follow is it's guided by the National Guidelines for Autism, the National Guideline for Assessment and Diagnosis of Autism Spectrum Disorders, which was released last year in 2018 by the Autism CRC. And so what they recommend in that guideline is that if you are an experienced mental health professional, so specifically a psychologist or a doctor, so a pediatrician or a psychiatrist, and you have experience in diagnosing autism spectrum disorders, you can make a single clinician diagnosis in that case. However, if there is any if you are unsure or uncertain, then the recommendation is to refer for a consensus assessment. And that tends to be what we see here at Orygen, isn't it, Mel? It's that we tend to see those complex presentations where it's not clear cut. And so what we're talking about in terms of best practice is this consensus assessment process. So the first thing we do is take a developmental history with ideally a family member or a caregiver who was present in the young person's life when they were very young, in their first few years of life, and then beyond there. That can sometimes be tricky in a context of a youth mental health service because those people aren't always available to be involved in assessments. So
or even if they are, it's hard to remember back that far.
Absolutely. So we try and work with the best information that we have. We might involve a few different people in this process as well. So, if mum had severe postnatal depression when their child was a baby, it's probably important to involve dad in that process as well to get some other collateral. Or there might be, in some situations where children's parents have gone back to work and the child was in the care of a grandparent, we might involve the grandparent to give us some of that information. Of course, with the young person's consent, that needs to happen.
And past assessments and reports, which we've got there as well, can be really helpful for that too, when it's hard for parents to remember. If they've got primary school reports, then we have a nice kind of insight into how they were behaving back then.
Other things that can be useful to have a look at as well in terms of collateral is maternal child health records and books and things like that, or medical records, kind of looking at developmental milestones and whether there were any flags kind of noticed in the early stages of life. So we gather the history, and then we move on to do an assessment of social and communication skills such as the ADOS, the Autism Diagnostic Observation Schedule. And basically that's an opportunity for us as clinicians to sit down and engage the young person in some social activities, and have a bit of a go at watching them and talk about and see how they communicate with us and how they interact with us. The ADOS is quite a standardised assessment, and we find with the young people that we work with at Orygen that sometimes we feel like it may not be exactly right for them. So some of the activities in the ADOS can come across as quite childish, and it can be hard to kind of sell that to young people. We do often preface it with saying, sorry, some of these activities might seem a bit childish, and that's not about insulting you or anything like that. It's just the only tool that we have available. We also find that the ADOS is one snapshot of a person's social communication skills, but again, we like to gather other information from other sources. So, for example, if a young person that we see at Orygen has been coming to group program, we like to consult with the group program clinicians to actually see how their social skills and communication skills are playing out in context. And then again, speaking with teachers and all of those kinds of people can be helpful too. As Mel has talked about, there are lots of cognitive differences that people with autism spectrum disorders present with, and people can present with severe intellectual disability all the way through to being quite gifted in their abilities. So we do offer cognitive assessments as part of the comprehensive assessment process so that we can get a sense about a young person's unique cognitive profile, and that can be extremely helpful in helping us make therapy recommendations and treatment recommendations, but also to help think about supports that might be required for the young person beyond their treatment at Orygen as well. So it might be in a school setting or thinking about particular vocational supports that might be helpful.
So we might discover, for instance, that a person has a preference and a strength in visual learning rather than verbal communication, and that's really helpful for thinking about ways of modifying therapy and ways of helping the school or their workplace to support them by using more visual information.
Ideally, a fantastic component of an autism spectrum disorders assessment that is so informative is having a speech and language assessment. So a common comorbidity for people with ASD is to have a speech and language disorder, so it could be expressive or receptive in nature. And speech pathologists are very well trained in obviously noticing those things, but also in pragmatic communication. So that is the more kind of social thinking skills that we've been talking about. So that's an essential part of the process. And then we also offer a sensory profile assessment. So for those, it's not always that we offer this, but ideally if there is a young person who's presenting with significant sensory difficulties with perhaps hypersensitivities, or there's some concern that they're not picking up on sensory information, a sensory profile by an occupational therapist is done in our service to provide some more detail around what's going on from a sensory preferences perspective. And that can be another really, really useful tool along with the cognitive assessment in thinking about what strategies people might be able to use to help them manage in different environments. So just some things to consider in terms of referring for a diagnostic assessment is thinking specifically about what is the purpose of the assessment. We often sit down with clinicians for secondary consultation, and the treating team will be saying this person needs a diagnostic assessment for an autism spectrum disorder, but actually the young person and their family may not necessarily be wanting the assessment to happen. It may not be as important to them as what it is the treating team. So we always ask that when referring for an assessment for ASD, that the treating team and the young people in the family feel really clear about what the purpose of that assessment is. What's the outcome going to be? What will the outcome be if a person is hoping for a diagnosis of ASD, because that's something that they feel like they identify with, but actually they don't meet criteria for that? What would that be like for them? Versus what would it be like to receive a diagnosis of autism spectrum disorder? If that could be quite shocking and upsetting for young people and their families and other support people to come to terms with, and can be quite challenging. So it's important to think about how that is going to be managed as well, and preempt if some of those difficult discussions might come up. And as we said, it's important to ensure that you've discussed these issues with the client and their family before referring for assessment. The other thing that's worth making note of is with the introduction of NDIS, we are seeing that there are some more referrals for diagnostic assessment for ASD, because people are, if they do receive a diagnosis we're being told of level 2 or 3 in terms of functional impairment, that they're more likely to be able to access a support package from NDIS, or a funding package from NDIS. So just bear that in mind, that might kind of, in terms of what is the purpose of the assessment or what is the driving need for the assessment, that's a common issue that's coming up for us at the moment.
Yeah, definitely. So we've had to think about screening and assessment and what autism looks like in young people. We're going to spend the last part of the webinar having a think about mental health comorbidities. So it's really important for you to understand that it really is the rule rather than the exception for young people with autism to experience a mental health difficulty. And there's this nice piece of literature from 2016. You can see there that it notes that in a particular sample of individuals with autism, they found that 95% had at least one comorbid mental health disorder, and that 74% had 5 or more comorbid disorders. And in the second paragraph there, you can see that as the severity of autism increases, so does the severity of psychiatric symptoms. So we're working with a really vulnerable population here when we're working with young people with autism that commonly have more than one mental health comorbidity. So we'll have a look at exactly what these comorbidities are and how they present. But in terms of some of the overall prevalence statistics, we know that overall they're 2 to 4 times more likely to experience a comorbid mental disorder than control subjects of the same generation without an ASD. We know that comorbid anxiety is very, very prevalent. I mean, that's quite a wide range of prevalence there, from 25 to 84%. But in our kind of clinical and anecdotal experience, I would say it's more on the upper end of that range. In fact, you know, there's talk at the moment about anxiety being included as one of the diagnostic criterion because it's so prevalent. So we know that 65% also experience a comorbid depression. That perhaps isn't surprising when we think about so many young people experiencing anxiety, and we know that anxiety and depression often go hand in hand. And around 19 to 30% of young people with autism also had a comorbid substance use disorder. And we'll speak a little bit more about that later, because that's a statistic that's been a bit surprising to some professionals working in the area, that have typically sort of held the view that young people with autism tend not to use substances as much as their peers. It's not the case, actually. Again, we have a pretty broad range there in terms of comorbid schizophrenia, from 0 through to 28%. But we do know that there is some evidence of higher rates of psychosis, NOS as well, or not otherwise specified, so that perhaps in people with autism, their experience of psychosis might look a little bit different to how it looks for other people.
Or they might have trouble reporting about their psychosis or the psychotic symptoms, which we'll talk a little bit more about later.
So having a think about some of the diagnostic difficulties that we might encounter when we're working with young people with autism. For instance, there's a lot of overlapping features and symptoms of autism and different mental health disorders. So, just a simple example of this is around, we talked about nonverbal communication and the fact that there might be reduced kind of use of facial expression in autism, and how, in things like depression or in psychosis, we might sort of see a blunted affect. And that's one example of kind of an overlapping feature that might be difficult to differentiate, and that we really need to think about the broader context of what else the person's experiencing and about their formulation and etiology as well, to understand whether or not we're dealing with an interaction of autism and mental health difficulties, or whether it's one or the other.
Yeah, and looking back at developmental history can be helpful in determining that.
Absolutely, it can be the differentiating kind of factor sometimes, can't it? Yeah. So another thing that can make diagnosis difficult is difficulties in self-report for people on the spectrum. So we've talked at length about the fact that difficulties with theory of mind and mentalising mean that it is hard to reflect on your own experience. And so that might be hard for people to be able to answer questions about their mental health. Yep. And so they might be more likely to fly under the radar in terms of feeling depressed, or that it might be more likely to kind of present behaviourally rather than to sort of self-report, I'm feeling depressed, for instance. We talked a little bit about some of the challenges of obtaining accurate developmental history as well, because this is, one of the really important things for differentiating autism from mental health symptoms. And this is especially the case for the group of young people that we work with up to the age of 25, when parents are really being asked to cast their mind back very far, and that can just be impossible in some instances. So there's some of the difficulties that we encounter. We're going to have a think now about anxiety in particular. Anxiety is the most common psychiatric comorbidity in autism, and it occurs throughout the lifespan. There can be differences in how it looks for children versus how it looks for adolescents and young people. So, for instance, in children, it might be more sort of somatic complaints like a sore tummy, for instance, or headache, or not wanting to go to school that it might present as. And then for young people, it might present more as social anxiety, social isolation. They might be more likely to use alcohol to cope with their experience of anxiety. So it can look really different throughout the lifespan. But we know that it's really tricky for a person because it interferes with so many aspects of their day-to-day life. So, school refusal is a classic and a really common difficulty. We also see issues with people really struggling to kind of initiate and integrate into working environments successfully as well. And likewise, difficulties with socialising, connecting well with peers. And if you're struggling with those day-to-day activities, then you're not getting as much enjoyment out of life, and the avoidance of those anxiety-provoking situations we know can lead to depression as well. So that's an extra vulnerability. It goes hand in hand with anxiety. We know it interferes with learning if you're struggling to be at school and struggling to get to work, and therefore that interrupts all of those sort of important graded developmental kind of tasks that are required for an adolescent and a young adult as they, gain greater independence and get a job and move out of home and all of those sorts of things. So that developmental trajectory can be interrupted anywhere along the line. Yeah. And that's something that parents can often be really concerned about as well for their young person, and of course for the young person as well. So we'll have a think about what might cause anxiety. We know that, as Joe's already mentioned, communication difficulties are part and parcel of autism. And if we think about, the difficulties that a young person with autism has in communicating with other people and with socialising with other people, it really leads to a lot of sort of anticipatory anxiety about those experiences. So that's a big cause of anxiety for them. We know that sensory sensitivities can cause anxiety as well. And that can be, going into an environment that's really overwhelming for the young person can sort of lead to that sensory overwhelm experience and lead to things like meltdown. So that's another big cause of anxiety. And we talked about, the preference for routine and sort of being in the same pattern day to day, which means that changes to routine and changes to environment can be very, very anxiety provoking. And likewise with an unfamiliar social situation, there's that sense of not really knowing what's expected. When you have trouble with theory of mind or perspective taking, you can't rely on that when you walk into an unfamiliar setting to know how to act. And so there's this fear of the unknown really goes hand in hand with autism.
And there is some sense that for those people who are on the lower support needs end of the spectrum or the high functioning end of the spectrum, you might have heard it called, is that the more awareness that they have of their social differences, but still not them being able to understand the social context very well, can make people more at risk of social anxiety in those contexts.
Yeah, absolutely. And again, having an awareness around the difficulties that you have in regulating your emotions can really cause a lot of anticipatory anxiety as well. So we'll have a think in particular about social anxiety now. So social anxiety, has a bunch of overlapping features with autism. We would often see sort of social avoidance and keeping to your comfort zone in both of those sort of conditions. But an interesting kind of difference in terms of social anxiety and autism is that, people with social anxiety will often say to me that they, have terrible social skills and they're really awkward and it's hard to get along with other people. But when you're having a conversation with them, actually they've got really excellent social skills and there's not really a deficit there. It's just that they have a perceived deficit or a fear of having social deficits.
And lack of confidence in their own abilities.
Exactly, yeah. And so, whereas when you're working with a young person with autism, they might actually have some genuine social difficulties and some deficits in terms of their social skills that they need to work on. So that's kind of one of the differentiating factors that we might notice. Another thing that we might notice is, the key cognition in social anxiety is around this fear of how other people evaluate you, or that they're going to evaluate you negatively. Whereas in autism, the fear might be less around being negatively evaluated by other people and more about the fear of the unknown social world. Again, coming back to these issues with theory of mind, they can't rely on that to sort of move easily in the social world and to be able to kind of understand what different people think and need and want in a moment-to-moment kind of way. So that can be very, very overwhelming and anxiety-provoking. Yeah. And I think, as you just mentioned, Jo, for folks that have lower support needs that are on the spectrum, they're more likely to have an awareness of their social deficits, which means that they're more likely to be anxious about being in social situations. And as we mentioned already, anxiety is the most common comorbidity, but in particular, social anxiety is the most common anxiety diagnosis. In this particular group, 47% of young people and children with autism had a comorbid social anxiety disorder. So really high prevalence.
Okay, so moving on now to other types of anxiety that we might see. A common differential diagnosis, or perhaps a comorbid diagnosis in lots of cases, is obsessive compulsive disorder, so OCD. So you can imagine that lots of the ritualistic or repetitive behaviours that a person with ASD might need to engage in on a daily basis. You can imagine that they might look to some people and some clinicians as potentially OCD type symptoms. So often people might come with a diagnosis of OCD and then the treating team kind of go, oh, hang on a minute, there's some really long-standing difficulties that might exist prior to that, and that's what might kind of flag for us that we need to go on and do some further assessment for ASD. So if we're thinking about the overlapping features, as I just mentioned, so obviously in both disorders there is a sense of ritualistic and repetitive behaviours, so we call them repetitive and ritualistic behaviours in ASD, and in obsessive compulsive disorder they might present more like rituals and compulsions that a person needs to engage in. The key thing to understand and try and remember is that with OCD, symptoms are ego dystonic, and can be quite distressing for people to, or are usually quite distressing for young people to be going through. So the need to engage in these rituals and have these compulsions to do certain things are often, really upsetting and have a huge functional impairment for this group of young people. Whereas in autism spectrum disorders, behaviours are not linked to intrusive thoughts, and they are acceptable or even preferred in lots of cases for people with autism spectrum disorders. So it can be helpful to try and understand what the person's experience of these behaviours is, and what is their drive to engage in these rituals. We know that can be tricky to differentiate because young people with ASD and OCD both might have trouble identifying expressing intrusive thoughts and talking about what's happening for them, engaging in self-report. But we do know that this is a very, very, very common comorbidity. And in fact, the literature is saying it's the second most common anxiety diagnosis for children and young people with autism spectrum disorder. So it's pretty common. Moving on to looking at a little bit at mood disorders, so specifically depression, again, because this is a very big comorbidity that we see here at Orygen. So we do have lots of young people that come into our youth mood clinic who may have an existing diagnosis of autism spectrum disorder, or they might come in and present as having lots of difficulties from a depressive symptom spectrum, but also that they might present with more long-standing difficulties, and so it's a common referral that we have to us. So if we think about, again, how it could be tricky to differentiate what's potentially autism spectrum disorders, a disorder versus depressive symptoms, you can see here that there's lots of overlapping features. So we know, as Mel said before, that in both disorders there's reduced verbal and non-verbal communication. So if you meet with somebody who's severely depressed, you will probably notice that they would have a blunted or restricted affect, and that can look like the lack of nonverbal communication that people with autism spectrum disorders can present with. Or people with autism spectrum disorders can keep to themselves and not communicate very verbally. And again, people with depression often keep to themselves and might have trouble with poverty of thought, and that might come across in their speech as well. We do see social withdrawal in young people with depression, particularly with moderate to severe depression, that they're often isolating themselves, and that may be coupled with social anxiety, as we've talked about. But social withdrawal, again, can be a feature of autism spectrum disorder. And I think the key often to try and work out here is from a social perspective, is this change in social behaviour and this withdrawal, is it a more recent issue? If it's a more recent issue, it might indicate depression rather than autism spectrum disorder. If we look back at the developmental history and there hasn't been a pattern of withdrawal throughout a person's life, we wouldn't be necessarily thinking it's autism spectrum disorder. Of course, depression and ASD can exist comorbidly, so a person may have already had a bit of a tendency to keep to themselves, but perhaps with depression on top of ASD, their withdrawal might be more significant and more severe. We would see in depression, we often see avoidance in terms of engaging in lots of different things in life, and again, you might see that with autism spectrum disorder, particularly for people who are feeling particularly anxious about going into different situations or new situations. And again, it's about working out what was present prior to the onset of mental health conditions, so what's been present in a developmental history or a developmental trajectory, and then thinking about what might have been more recent.
I think that's a common theme that we see throughout the comorbidities, is the importance of taking the developmental history and understanding, the onset of the mental health difficulties along the lifespan to try and differentiate, is this, ASD plus depression or plus social anxiety or OCD?
Or is it one or the other?
Yeah.
Again, with depression, you see problems initiating activities. So people, in terms of their motivation, and maybe they might be experiencing anhedonia and not enjoying their activities. But again, as Mel mentioned before, when we're thinking about people with autism spectrum disorders, they have trouble with executive functioning, which might impact on their ability to start activities and engage in activities. And then if you couple that with anxiety about change, starting new activities or getting out and about and doing new things can be really, really tricky for that population. In both depression and autism spectrum disorders, we do see a tendency to have repetitive and rigid thinking patterns, and particularly with people who are very depressed, that their thinking styles can be very black or white. Their negative automatic thoughts can look very black or white or very rigid and can be hard to shift. So again, it can be tricky to differentiate what's what. And in both disorders, we see difficulties with sleeping and eating. The other thing to keep in mind with youth and with children and adolescents and young people with autism spectrum disorders is that because of the difficulties they have with identifying and talking about their own emotional experiences, they may not use words to describe depression in the way that other people might. So they might not say things like talk about sadness or helplessness or loneliness or those kinds of things, or use the term depression. But they may be presenting with a real change in their behaviour or their presentation, and that can often look like anger, challenging behaviours. And so we need to be kind of thinking about whether those behaviours, anger or irritability, might be masking other features of depression. So that's, I guess it's very important to take a good history for depressive symptoms that looks at the whole spectrum of depressive symptoms, not just asking about the feelings and emotional states.
Yeah, and another way that masking can present with depression is thinking about avoidance and the use of special interests. So, you know, if a person has a special interest in gaming, they may have had a long-standing interest in gaming and always enjoyed gaming, but that might be the only thing that they do now.
Just touching on a couple of other disorders that I guess are not as prevalent. What is important to keep in mind is that, again, we might see a crossover between autism spectrum disorders and psychosis. So there are lots of features that might look similar. So we've put a little graphic up on the screen for you there, and we might pop this in your A4 resources as well. That looks at, this is how Mel and I tried to make some sense around looking at psychosis and ASD. So you can see there's a whole range of different traits of ASD on one side in the green, and then on the blue side of that diagram it talks about the features of psychosis. So we won't go into that in a huge amount of detail today, other than to say that, again, it comes back to developmental history, and it's important to understand the onset of when difficulties happened. Touching on personality disorders, again, it's hard to go through this in a lot of detail today, and we've popped an article link there if you want to go away and have a bit more of a look at this. But the prevalence of certain personality disorders in people with autistic adults is quite high, actually. So you can understand when you learn a bit more about autism spectrum disorders why people might be scoring highly on screens for personality disorders such as obsessive compulsive personality disorder, why they might be presenting like they have avoidant PD. Again, a potential look of lack of interest in socialising might present also like schizoid PD. People with autism spectrum disorder might look like they have paranoid PD because they might sound like they're paying lots of attention to the social world and kind of misinterpret or kind of worry about what other people are thinking or doing, and might struggle to interpret what the interactions or the meaning behind the interactions is from others. Schizotypal PD is a really kind of common differential diagnosis that we see at Orygen, and also is borderline personality disorder. There are lots of crossover features there, particularly around difficulties with regulating emotions, self-harming behaviours, and those kinds of things. Difficulties with relationships, of course. So have a look at that article if you're interested, because that's a great summary.
Yeah, and that article, by the way, talks about lots of different comorbidities, including sort of axis 1 or mental health conditions, not just personality disorder.
Just touching also on substance use disorders. So as Mel mentioned, it's I guess it's a bit of a myth that people on the spectrum don't experience substance abuse and dependence, but actually there are some things about with relation to their presentation that might make them more likely to engage in substance use. So people with autism spectrum disorder can be quite impulsive in their actions, and that can make them more likely to engage in an activity without thinking about it, and they might be more compulsively more likely to engage in activities. Also, sometimes people are seeking very strong sensory input, so they might want to take an amphetamine or something like that to provide some extra sensory input and stimulation. Or they might be trying to dull sensory experiences, or they might be using substances to manage social anxiety if they're experiencing social difficulties. So there's a range of reasons why people might utilise these, and because of their tendency to engage in ritualistic behaviours, it can make them more at risk for addiction as well as their bodies being potentially pretty sensitive to psychotropic things and substances in their body. Just touching very quickly on self-injury, I think we could talk about that for a whole webinar on its own, and I know that other mental health professionals from Orygen have done so. But specifically with regards to people with ASD, we know that self-injury can be very distressing for young people, their families and workers, and you might see things like when a person is in a state of meltdown or sensory overwhelm or distress, that you might see head banging, skin picking, scratching, biting themselves, pulling their hair, hitting themselves, strangling themselves, or cutting themselves as well. So it could be quite alarming for people. When thinking about self-injury in autism spectrum disorders, it's a really, really complex issue, particularly when a person has difficulties communicating their needs and communicating what's causing them to be overwhelmed. So it's important to understand the function of the self-harming or self-injury behaviour. So it's important to think about whether it's a sensory stimulation activity, like a stimming, repetitive behaviour that a person might be engaging with from an autistic perspective, whether it's related to sensory overload, whether they're trying to communicate distress, whether it's another kind of soothing, repetitive behaviour, whether they're wanting to communicate a mental health problem such as depression or anxiety and they can't find the words to describe it. Or whether it might be indicating that they're having some sort of physical health difficulty that might be hurt, there might be pain that they can't communicate. So this is often with the non-verbal population, but thinking about whether they've got a cold or an ear infection or something going on in their digestive tract. So,
or for younger adolescents as well, we might see some of those difficulties in communicating, physical health difficulties.
So today we've given you an overview of autism spectrum disorders and how they present uniquely in adolescents and young people, and hopefully we've given you a bit of a snapshot into kind of what the diagnostic process is and thinking about what common comorbidities you might come across in mental health settings. We would encourage you to continue with your learning. We have put together a learning module for how to engage with and work with young people with autism spectrum disorders that we hope you'll take a look at, and that will have a bunch of activities in it that you can work through as well to support your learning. So thanks for joining us today. If you do have any follow-up questions for the webinar, feel free to utilise the contact details there to get in touch and ask any questions that you might have. But thank you for joining us today.
Yeah, thanks for coming.